عليكم ورحمة الله. نرجو من الجميع الحضور الوقوف لأداء السلام الملكي السعودي. Please, ladies and gentlemen, stand up for the Saudi national anthem. Good morning, colleagues, friends, ladies and gentlemen. Assalamu alaikum wa rahmatullahi wa barakatuh. We would like to welcome you all to our first Almoosa International Echocardiography Conference. It's our great pleasure on behalf of my colleagues, the cardiology team at Almoosa Specialist Hospital, to welcome you all. And as we all expect in this conference, inshallah, we will see and present the latest update in echo field and related clinical practice. And this will include the discussion, interaction with colleagues from all over the Kingdom of Saudi Arabia, as well our international guests. Without further ado, let's start our conference opening with Sheikh Ahmed Al-Bu'ainain for the Holy Quran recitation. يتفضل سماحة الشيخ أحمد أبو العينين لتلاوة ما تيسر من القرآن الكريم، فليتفضل مشكورا.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. ألم تر إلى ربك كيف مد الظل ولو شاء لجعله ساكنا ثم جعلنا الشمس عليه دليلا ثم قبضناه إلينا قبضا يسيرا وهو الذي جعل لكم الليل لباسا والنوم سباتا وجعل النهار نشورا وهو الذي أرسل الرياح بشرا بين يدي رحمته وأنزلنا من السماء ماء طهورا لنحيي به بلدة ميتا ونسقيه مما خلقنا أنعاما وأناسيا كثيرا ولقد صرفناه بينهم ليذكروا فأبى أكثر الناس إلا كفورا صدق الله العظيم.
صدق الله العظيم. It's my pleasure, ladies and gentlemen, to give you an overview of Almoosa Specialist Hospital Heart Center. We are proud that our center offers a wide range of cardiac services, advanced technology to expedite the diagnosis and treatment, featuring the latest cardiac technologies such as advanced echo modalities in the form of speckle tracking, arterial and ventricular strain, 3D volume that aid in early diagnosis of cardiac dysfunction and have a unique role in cardio-oncology patients. The myocardial perfusion scan using a nuclear image, a hybrid operating room that combined with a catheter and surgical modalities along with the electrophysiology lab. And all of this effort was made to ensure a better outcomes for our patients. So please, if you will allow me, we will run a video that define our cardiac center in Almoosa Hospital.
Almoosa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardiology clinic. 1 vascular clinic. 2 cardiothoracic clinics. 3 echo labs. 1 stress test room. 1 electrophysiology lab. 1 tilt-table room. CC floor with a capacity of 17 beds. 2 cath labs. 1 hybrid OR. A team of humans taking care of our fellow humans. With technology that has the answers and minimally invasive options to keep the power of together with your hearts and their little ones. Almoosa Heart Center. Technology saves lives. 6 adult cardiology clinics. 1 pediatric cardio.
Now we would like to welcome on the stage Dr. Hussein Al-Quraini. He is the Deputy of Academic Affairs, the Director at ASH. Dr. Hussein will give us a welcome speech on behalf of Almoosa Specialist Hospital. Please welcome him on the stage.
Assalamu alaikum. Good morning, and thank you very much for your attendance. Dear colleagues, professors, lecturers, researchers, ladies and gentlemen, it's truly my pleasure on behalf of Almoosa Specialist Hospital to welcome you all to this activity, the first echocardiography Almoosa Specialist Hospital meeting. I'm confident this meeting will achieve its objective, basically establishing a forum for collaboration to exchange ideas and knowledge to help us advance research and ultimately take care of our patients. Special thanks to the organizing committee, Dr. Ala and the rest of the team, who did a lot of work behind the scene to basically bring this very nice program. Also, a special thanks to our partners in the Saudi Society for Echocardiography for their support as well. So we have very nice program, and I'm sure you will find a lot of interesting discussions, a lot of knowledge sharing, and hopefully we want this to continue during the sessions and after the sessions as well. So I wish you a very productive meeting and very productive day. Thank you very much.
Thank you, Dr. Hussein. You have been always a figure of our hospital. Now, ladies and gentlemen, we would like to let you know that by the end of this scientific day, inshallah, we will have an interesting interactive competition between teams in Eco Jeopardy. which will be directed by Dr. Jamila Rahimi. Dr. Jamila, she is a consultant, non-invasive cardiologist, chief of cardiac center at National Guard Hospital in Jeddah. It's our pleasure again to invite Dr. Minwar Al-Majnouni. Dr. Minwar, he is a head of Saudi Society of Eco, and he will give us a speech on behalf of the society.
Good morning, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Honorable guest, distinguished expert, ladies and gentlemen, it's my great honor to be invited to attend the opening ceremony of Almoosa, first Echo Conference in Almoosa Hospital. On behalf of the Saudi Society of Echocardiography, I would like to extend a very warm welcome to all present here, respected attendees and speaker. And I would like to thank all the people behind this great gathering, especially the academic affairs here and Dr. Ala, who is make this gathering great for us as echocardiographer and practicing the service. I extend my sincere thanks to all the speakers and attendees for their effort and support. It's an honor to be graced by the presence of distinguished and eminent speakers as well. And I feel privileged to open this event and stand here where many accomplished people who I admired and look up to stand. This is indeed an important occasion for all of us. And those who is practicing the echocardiography to exchange the knowledge and experience as well as the new technology in this field. I would like to have this event yearly happening because it's very important for us, and especially with the it's enriched the knowledge in the echocardiography field for us as echocardiographer and cardiologist as well. Many thanks for you, Dr. the Academic Affairs Director here, for everybody here attended this event. Thank you very much.
Thank you, Dr. Minwar, for this nice speech. Now let's welcome on the stage Dr. Ala Khalil. Dr. Ala, he is a consultant cardiologist, the head of non-invasive cardiology lab at Almoosa Specialist Hospital. He is the conference director. Please welcome him on the stage.
Bismillah ar-Rahman ar-Rahim. It's my pleasure to welcome you all for attending the first Almoosa Echo Conference. Really, it was my dream since I came to Al-Ahsa to make such important scientific events, same as we was doing in the western area at Jeddah for the 8 consecutive years. And it gained the interest of the most of the cardiologists there. Really, I was eager to bring such respected, beloved groups of echo experts to be here in Al-Ahsa to enrich the medical field with most recent advances in the echo and enjoy discussion of the different cases. This conference wouldn't be existed without administration support headed by Mr. Malik Almoosa and Dr. Zainab Almoosa, the head of the academic affairs. Yesterday was the first day for the conference, and we ran yesterday 3 workshops, and it ended by the very attractive event, which is the interesting Echo Case Forum, where 14 cases were presented from all over the kingdom. And our expertise referees, Dr. Hassan Shams Basha, Dr. Abdulhalim Kinsara, Dr. Fatma Abu Al-Ainain, and Dr. Hani Mahmoud, selected the best 3 cases according to the performance and another criteria. After now, it will be the video about the activity yesterday, and after that, will announce the names of the winner, the first three winners, and will be honored here with the very precious prize, inshallah. So now we'll run the video. Everybody think he will be the winner, inshallah.
Now we conclude our opening ceremony by inviting Dr. Hussein, Dr. Ala, and Dr. Manwar to the stage to announce the best case presentation winners. Please welcome on the stage.
We'll start with the third winner. The third one, Dr. Hatem Khirallah. Where is he? He's not available?
He's enjoying the weather, maybe. It's raining outside.
Okay, we'll give him his prize. The second winner, Dr. Tariq Al Hussein.
I was not expecting that.
You deserve
Thank you
more.
very much. Thank you very much. Thank you very much. Thank you very much.
تعال في الاستديو جوه كده عشان نصور. And now we are coming to the first winner, who will be Dr. Abdurrahman Jamil.
Now we would like to recognize our partners for this successful conference, hopefully. Starting with a company, Philips. Anyone representing Philips company? Dr. Ala. Yeah. Yeah, okay. Now we would like to recognize also Novartis. Novartis. Please welcome to the stage. Now also for Al Faisaliya. He will receive for all companies. Our successful partner also, Amgen. Anyone will represent the Amgen? Doctor, you can come. I'll see. And the last is Hilrom Al Qusaybi. Welcome to the stage.
Thank you for attending the opening ceremony, and now we'll start our program. I would like to invite Dr. Abdulhalim Kinsara, Dr. Minwar Majnouni, and Dr. Abdullah Al-Ali to the stage to start sharing the first session today.
طيب من هو قدم الثاني انا اقدم الثالث خلاص ممتاز. السلام عليكم ورحمة الله وبركاته. بسم الله الحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. So we'll start the second day and I'm sure will be a very educational day. Inshallah, very successful day. Today we'll be speaking about the strain. So as you know, strain is a very important thing, and we have really to use it more frequently in our daily practice. It's a learning curve, but as you saw now with the software, it's really automatic. So I think we should really be more familiar with using it. Our first speaker is Dr. Ashraf. Dr. Ashraf is at the Ministry of Defense and Aviation in Jeddah, King Fahd Hospital. He's going to speak about when you need speckle tracking in clinical practice. Ashraf, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Abdulhalim, for introduction. Thanks also for Dr. Ala Khalil inviting me to share in this session. This presentation will be just a continuation from we started yesterday regarding the application of speckle tracking. But today's we'll targeting to speak about the clinical daily practice for this speckle tracking. And the same question we raised already yesterday was raised several times by the article. Is it just for research work or it's now ready for application in daily practice? Before to answer with yes or no, we have to say that speckle tracking fulfills the criteria for any modality to be applied or not, regarding the feasibility, regarding objective information, regarding the cost, regarding strong evidence from the studies, and all of these or most of these criteria have to be fulfilled for any modality we are using in daily practice. As you know, the development of echocardiography starting from MO, 2D, tissue Doppler, contrast, everything, the only target or the main target was left ventricular systolic function. But unfortunately, the only parameter targeting to assess accurately was the ejection fraction, starting from subjective evaluation, ending with the heart model like you saw yesterday, only ejection fraction. But as we explained yesterday, it's just a number, ejection fraction. It's not expressing the whole function of the myocardium or the whole function of cardiovascular performance. You may have patient with low ejection fraction with good perfusion and there is no symptoms during rest or during exercise. On the other hand, you may have patient with cardiogenic shock and function or ejection fraction is completely normal or supernormal. And during the follow-up also, you can say that this patient have normal ejection fraction, but while they are following without any cardiac events, they have impaired ejection fraction. So we can't rely totally on ejection fraction for assessment of cardiovascular performance. It's not a negligible parameter, but we have to add a lot of information in addition to this ejection fraction, which is a parameter of contractility. We explained yesterday that we have many types of strain and strain rate regarding longitudinal, circumferential, radial, layer specific, and all of these have evidence, but the most one have strong evidence was longitudinal strain. And the global longitudinal strain is also standard. You can rely on epicardial, endocardial, myocardial, but we have to end it with the global longitudinal strain with the global evidence. And this as answering for the question. This is a survey done in Europe, including 96 centers using echocardiography, using speckle tracking. And the answer for most of them was we are using this for patient with chemotherapy, patient with cardiomyopathy, patient with heart failure with preserved ejection fraction, patient with valvular heart disease, and the other indication was less interested for these centers. Why they selected this? It's not a subjective opinion, but regarding this with a strong evidence from the whole statement from American Society, Canadian Society of Echo, and also from literature already available. If we started with the first indication, CTRCD, cancer-related, therapeutic-related cardiac dysfunction. And all of us know that even radiotherapy or chemotherapy affecting the heart by many mechanisms. Unfortunately, we have the latest guidelines from cardio-oncology, European guidelines, 2022. And to be aware with the size of the problem, that all therapeutic therapy for the cancer, radiotherapy or chemotherapy affecting the heart with a considerable percentage. Even with the development of new agents, we still have higher incidence of cardiovascular dysfunction. And the message from these guidelines was class 1 indication to apply echo for assessment of those patients before, during, or after chemotherapy. If you have facility to assess this patient with 3D ejection fraction, it's class 1 indication. If you have global longitudinal strain, also class 1 indication to assess those patients. And the global longitudinal strain is not just a modality to diagnose, but it has a rule for every stage, for a prediction of development of cardiac dysfunction, for even the definition, accurate definition, and also for the prognosis. And we have this number from the literature. If it's the change of global longitudinal strain more than 11%, is a strong predictor for development of cardiovascular dysfunction. If the global longitudinal strain below minus 17.5, the risk with 6-fold development of cardiovascular dysfunction. With the cancer, breast cancer therapy, reduction less than 19%, even after they finish the therapy, also anticipated CTR-CD. Before the guidelines, we have also clear statement from American Society of Echo and European Association of Cardiovascular Imaging, American Heart Failure. All of these stated that there is higher evidence of cardiovascular dysfunction with cancer therapy. And this is the definition, stated definition and standard definition. If you have more than 15% reduction in GLS, this compared with the baseline we started before the therapy, this is the definition of CRTD. If you relied on ejection fraction more than you reach the level of 53%, this is also diagnostic for cardiovascular dysfunction. And this is just an example. If you relied on ejection fraction by the 2D, in this patient before he started, sorry, it's not working. Before we started the therapy, it was 60%. Sorry. it was 60%. By the 3D, it was also 60%. After he started the treatment, just 3 months, it was 60 or more than, so it's improving even by the chemotherapy. But the ejection fraction by the 3D show difference between the baseline and the treatment. The most one was famous, was clear for this patient, was GLS. He started by around 20%, and now he's 16%. After he started modification of the doses and he started to cardioprotective medication, it shows improvement of ejection fraction by the 3D. Nothing happened to the ejection fraction by the 2D, but the global longitudinal start to show also improvement. So this is mean we can rely accurately with the GLS for the patient with the chemotherapy, or if we have ejection fraction by the 3D, it will be also informative. And this is a clear statement also included around 1,700 patients or more than 1,700 patients with cancer therapy for systematic review. It shows that if you have patient with cancer therapy and he developed GLS reduction, the prevalence of cardiovascular dysfunction in the future or exercise intolerance or impaired cardiopulmonary fitness will be in a higher percentage of those patients. And simply you can follow this algorithm by American Society of Echo. If you have drop of ejection fraction below 53%, yes, this is diagnostic. But if still ejection fraction is not affected, you have to rely on GLS. If it's reduced less than 8%, no, still have patient with good function without development of left ventricular dysfunction. But if the GLS started to be decreased more than 15% compared to the baseline, this is diagnostic for subclinical left ventricular dysfunction. If you haven't a baseline and you just faced with the patient with this chemotherapy, also look for the ejection fraction. If it's 60% or more, no need to do any further investigation. But if the patient is already have borderline 50 to 59, rely on go direct for GLS to see if it's reduced or not. If it's reduced, it's diagnostic for LV dysfunction. And we have to be cautious with those patients, not only GLS or ejection fraction. This is a protocol standardized also by the latest guidelines for those patients to assess RV with all these parameters, including free wall left ventricular strain, and also all these parameters for LV, including also GLS. And to diagnose left ventricular dysfunction or right ventricular dysfunction, we have to fulfill all these criteria. If the longitudinal strain for the free wall of the right ventricle less than 20% is diagnostic. And also on the other hand, if the reduction of ejection fraction quantified by the 3D dropped by 5% or global longitudinal strain dropped by more than 15%, this is also diagnostic for LV dysfunction. We have a lot of information from these guidelines. If you are interested with this field, you have to rely on it and go back to further details with each type of cancer and each type of medication. For the sake of time, we have to move to the second indication is the heart failure. And according to the latest guidelines, we will not rely on GLS for classification of the patient. We are still relying on ejection fraction to classify patient with recovered or impaired or preserved or mildly reduced. But again, GLS can add a lot of information for those patients in addition to ejection fraction regarding the prognostic value, not for diagnosis of heart failure. Why? Because we have these tables showing to us that even in patients with normal left ventricular function, a considerable number of them have borderline or reduced GLS. And during the follow-up, as we said before, we can rely on GLS better than to rely on ejection fraction. And this is a major class of patients with heart failure with preserved ejection fraction. They found that a considerable number of patients with preserved ejection fraction have impaired GLS, and this impaired GLS was also associated with higher biomarkers and higher diastolic dysfunction. And even before the development of heart failure, this Copenhagen study included normal subjective patient, normal general population participated in this survey, and they followed them for 11 years. Also, again, a considerable number of patients have impaired LGLS was associated with poor outcome. 18% died with major cardiac events. Again, for a general population, another article also showed that the lower GLS was associated with bad or high risk composite endpoint, and it was used the post-systolic Systolic GLS, systolic index was a parameter even better than we are using Framingham study, Framingham score, or American Heart or American College of Cardiology score. So we need GLS not for diagnosis or classification of patient with heart failure, but we need for the prognosis of the patient with impaired ejection fraction. We need it for prognostic or diagnosis if it's questionable in patient with borderline or mildly reduced, and even in patient with preserved ejection fraction. And we can follow this algorithm. From the start, we have patient with cardiovascular assessment, and we already assessed ejection fraction. If we still have doubt about ejection fraction, we have to use GLS. If we're already confident with the ejection fraction by 3D or by 2D, and patient already classified as impaired ejection fraction, we still need GLS for a prognosis or for selection of patient with ICD. If we already have preserved ejection fraction, and there is possible this patient already recovered, he was impaired, and then now he recovered, we need also GLS for this patient. If we have the definite diagnosis for amyloidosis, for LVH, for valvular heart disease as underlying etiology of heart failure, we need to check also GLS. If the patient have preserved ejection fraction and image quality is super, no need for further investigation, but with patient is still high risk for heart failure, we need GLS. So nearly we need GLS for those patients with heart failure in all stages of heart failure. And this is a nice study recently published regarding the utility of 3D speckle tracking in heart failure, and already I'm referring anybody interested in this field. As underlying etiology of heart failure, the cardiomyopathy is the major one, and we have a big list of cardiomyopathies. Let us see how can GLS or strain quantification help us in this part. If we started by the first step, acute myocarditis, development of acute myocarditis, there is no imaging modality by echo available now to test this patient. We may say that borderline ejection fraction, we may say that some questionable wall motion abnormality, but if you did strain rate for those patients, you may detect the area affected by this myocarditis, and it was already comparable with the biopsy already taken from this patient. If we started with dilated cardiomyopathy, as a diagnostic criteria, all types of strain are used on those patients, and both ventricles are involved. But this is the major important point, that in those patients, the left ventricular twist also is reduced in those patients. For premature phase of dilated cardiomyopathy, despite the global ejection fraction was not affected much, or despite no discrimination between genetic and non-genetic, the early phases GLS can help you to diagnose those patients. And the major question, patients who have impaired ejection fraction and wall motion abnormality is globally affected. Is it ischemic or non-ischemic? Sometimes in patients with multivalvular disease with balanced ischemia, you will not be able to discriminate. But this is the major criteria you can discriminate by speckle tracking. Both are impaired, ischemic or non-ischemic for GLS, but the relative sparing of the apex compared to the base is a diagnostic sign with higher sensitivity and higher specificity, especially if you make a ratio between the basal strain to the summation of mid and apical strain with a ratio of 0.4 or less, it will be higher sensitive and specific to diagnose ischemic and non-ischemic. This is a patient already recovered ejection fraction after they received the medical treatment, and we can see now that a considerable number of them have impaired GLS, and this impaired GLS was associated with worse outcome. 17% of them died. But if the ejection fraction is recovered and GLS more than 18, it was not associated with poor outcome. And this is a curve. After improvement of ejection fraction, you may have patient with ejection fraction less than 40% or more than 40%. If you add GLS to them, if the GLS is still worse, the prognosis is still bad. It's not like the patient with ejection fraction 40% or more and normal or improved GLS, and the cutoff value in this study was -13. Not only the patient, but even the relatives, without any symptoms, without any affection of ejection fraction, they divided this patient, and they saw if the relatives have impaired GLS, it will be also associated with cardiac events with hospitalization, death, and development on the future of heart failure. If we moved fast to the another category of cardiomyopathy is cardiomylosis, and yesterday we have already some information about this in the case presented yesterday, that if you have unexplained left ventricular wall thickness more than 12 millimeter with one of these criteria, it's diagnostic. And this is the latest statement from European Society of Cardiovascular Imaging. One of these was reduced ejection fraction below 15%. And this is like we are expressing it, cherry on top, apical sparing. But if we used the ratio as a marker, we have a sensitivity of 93% and specificity of 83%. If you have apical sparing at least one, this is diagnostic for the amyloidosis. And even here, if you have reduced basal less than minus 11.3, sensitivity also is higher. If you relied on both ejection fraction and GLS, and you make a ratio between of them, and the ratio was more than 4%, it's much, much higher specificity and sensitivity for diagnosis of amyloidosis. And you may say that this is the apical sparing. Sometimes mid-segments also involved, and this is a different pattern. But even if you relied on the ratio as we explained before, it will be diagnostic for your treatment. And this is also another article regarding the 3D speckle tracking involvement, and the same message was reduction of GLS was associated with a poor outcome, and the ratio is still the same for the 2D speckle tracking or 3D speckle tracking. In hypertrophic cardiomyopathy, all of us are relying on the wall thickness, and we have already latest guidelines with the assessment of this function, and this is one of the review articles. We already collected the most available data applied for the hypertrophic cardiomyopathy, and the collection of studies shows that if you have reduced ejection fraction, it's already diagnostic. But if you have preserved ejection fraction, most of these patients have reduced left ventricular global longitudinal strain and strain rate. And the most diagnostic things that we already explained yesterday, how it can patient with preserved ejection fraction or normal or supernormal ejection fraction, especially patient with HOCM, and reduce the strain. At that time, at early stage, longitudinal strain is impaired, but the compensatory mechanism was elevated circumferential and radial strain. And again, the famous question, is this athletic heart because he is muscular, or this is hypertrophic cardiomyopathy? The only criteria, or one of the major criteria, was decrease the longitudinal strain in patient with hypertrophic cardiomyopathy, while in athletic heart it was normal or not affected. And this is also a statement from European Society of Cardiography, regarding the athletic heart. It's not a routine to screen the patient with athletic heart, but if you have doubt, we have to rely on the global longitudinal strain. And if you found reduced the global longitudinal strain, you can't explain that this is due to his powerful exercise because he's doing isometric exercise. No, it's not, cannot be explained by his physiological adaptation or adaptation to exercise. A third one, or another type of cardiomyopathy, Takotsubo cardiomyopathy, we are not relying much on global longitudinal strain to diagnosis, but at least you can define the segment affected. It's not only apical, as we assumed, it's a higher percentage of them are apical ballooning, but other also area can be affected in those patients. If we move, then we have time for the pericardial disease. Patient with constrictive pericarditis also showed reduced circumferential strain, reduced longitudinal strain, and even if we did the ratio between septal longitudinal strain and the apical straining, we have also this information. Now it's reversed between the base and all segments. And a famous question also, it's constrictive pericarditis or restrictive cardiomyopathy. We can also rely on the global longitudinal strain because patients with restrictive cardiomyopathy have all these patterns, while the patient with constrictive pericarditis is localized to the area of affection of the pericardium. And for the definition and diagnosis, I also refer you to this article. You have a lot of details regarding other echo modalities, tissue Doppler and also M-mode, but the global longitudinal strain have its point here. Nearly we now end with the conclusion that strain rate is a sensitive and reproducible parameter to quantify myocardial function in different categories of patients, and you can rely on it for diagnosis, for prognosis, and for follow-up of those patients. And some of these indications have higher sensitivity and higher specificity in addition to other cardiology parameters. And thank you for it.
From Egypt, sorry, any question? I have no question. I want to present the other. Okay. At the end of the session, yeah.
طيب شكرا. الله يعافيك شكرا جزيلا.
شكرا جزيلا.
Thank you.
From Egypt will join us Prof. Mahmoud Shihata. He will talk about the point of care ultrasound. Is it worthy? Point of care is a new emerging technology as an echocardiography.
Good morning, everyone. This is Mahmoud Shihata from and thanks for having me at this elegant conference. And my talk today will be about spectral tracking of cardiography with no more complementary rules. This is my disclosures. I have nothing to disclose. And first of all, we have to define what is spectral tracking echocardiography. Spectral tracking echocardiography is a method whereby spectral artifacts, which are small areas of bioelectrogenicity within an ultrasound image, are analyzed. And by tracking these spectral within the ventricular walls throughout the cardiac cycle, to give us information about the motion of these vectors, the direction, the velocity, and the displacement. And by comparing this motion of individual spectals with each other, will give us sensitive segmental or global deformation analysis of the myocardium during systole and diastole. The basic parameters of spectral tracking echocardiography are the motion, displacement, velocity, the deformation, which are strain rate. So the motion in terms of displacement and velocity are the vectors of motion, and displacement is a vector change of position of an object in distance and direction measured in units of length, while velocity is a measurement of this displacement measured in units of length per time. A positive or negative sign are specific for the direction of motion, while the deformation parameter is strain and strain rate. Strain is the degree of deformation of an object. Stretching relative to its original length and is expressed in percent. Strain can be negative, while the object is shortening, and positive while the object is lengthening. And looking at this diagram, we have a longitudinal strain, radial strain, circumferential strain, longitudinal strain, and circumferential strain. During systole, the muscle will shorten, and during diastole, it will lengthen. While the radial strain during systole, it will thicken, while in diastole, it will thin out. The force behind this strain is called the stress, and the relation between stress and strain is called cardio compliance. The strain rate is the rate of the strain or the deformation, and this means the change in strain per time of unit, per unit of time, sorry. This object can have the same strain, but different strain rates, like A and B. They have the same positive strain, but the strain rate of the object A is higher than B. A moving object does not undergo deformation if every part of the object moves with the same velocity. Like stiff or fibrotic sections of myocardium post-myocardial infarction can still have motion due to tethering from the surrounding healthy muscle, but this is not deformation, this is a passive movement. And if different parts of an object have different velocities, the object will fall
This means changing shape. This objects A and B, object A is moving with all parts at the same velocity, so this motion but not deformation. While the object B is moving with different parts having different velocities and differential motion and deformation. Tracking echocardiography is a sensitive tool for assessing ventricular function in subclinical myocardial alterations that traditional imaging techniques like ejection fraction are not able to detect. Subendocardial function is powered mostly by longitudinal contraction. It is impaired earlier than circumferential or radial components. Therefore, longitudinal function is in most cases the best early marker of left ventricular dysfunction. And this is recommended to use global impedance training. And time to peak analysis either segmented across different segments of the myocardium in the longitudinal or an average of all segments for the global strain rate. So spectral echocardiography is a good modality and utility. But for a long time, it is only just a research tool. So you have a very good tool, a very good modality, which is born to be a leader, but you have still to put it in the baby seat. So it's time to prove yourself. I'm talking about spectral tracking. And one of the fields of spectral tracking utility, great utility actually, is the assessment of elemental systolic function, which are usually assessed by traditional methods like ejection fraction, AV volumes, and sense mode, and mode, and whatever the method can measure ejection fraction by. And these traditional methods are load dependent, but strain and strain rate can accurately estimate regional myocardial contractility. The strain will express the instantaneous deformation of the myocardium and directly describes its contraction and relaxation pattern, while the strain rate expresses the velocity of myocardial deformation. The main advantage of strain and strain rate analysis compared to myocardial velocity measurements is the ability to differentiate active contraction from passive contraction, resulting from local harsh translation from the pulling by surrounding myocardium. Moreover, the myocardial deformation is less dependent than myocardial displacement. The guidelines of recommendation for cardiac chamber quantification by echocardiography in adults, published by American Society of Echocardiography, recommended that elemental systolic function should be routinely assessed using 2D or 3D echocardiography by calculating ejection fraction in the systolic volume and systolic volume. And they stated that the two-dimensional spectral tracking echocardiography derived in global ejection strain appears to be reproducible and feasible for clinical use and offers incremental prognostic data over LV ejection fraction in a variety of cardiac conditions. In connection with post-MI, the LV assessment, to be accurate, you have to assess the cardiac mechanics, and which has been proven elusive to traditional imaging using spectral tracking echocardiography, in part due to the common spatial orientation and distribution of the muscle fibers in the longitudinal and circumferential direction. Spectral tracking echocardiography derived strain rate are more accurately reflecting intrinsic measures of myocardial contractility and they enable quantification of regional myocardial deformation. They give us new insights in patients who are post-MI with almost similar ejection fractions, but some patients are compensated and some are not. These new insights come out of spectral tracking echocardiography recent studies which compare longitudinal and circumferential functions, which have shown that longitudinal function deteriorates early under cardiac pathologic conditions, whereas circumferential function may remain relatively resolved to compensate for cardiac function when longitudinal function starts to become dysfunctional. This comes out from the famous Valiant study, where they studied the longitudinal circumferential strain rate, left ventricular remodeling and prognosis after myocardial infarction in a subgroup of the Valiant cohort. The Valiant study, as you know, occurred valsartan limb versus captopril limb versus valsartan captopril limb in around 15,000 patients. Out of these 15,000, there are 600, almost 600 patients with echo data, and they divided these 600 cohort, sub-analyzed this cohort into patients, around 380 patients, where they studied the laryngeal strain and strain rate, and 420 where they studied circumferential strain and strain rate, and around 311 was studied for both laryngeal and circumferential strain and strain rate analysis. And they concluded that the longitudinal strain rate added significant incremental prognostic value to baseline LV ejection fraction and clinical variables in prediction of all cause mortality after high-risk myocardial infarction. Circumferential strain rate helps predict long-term LV remodeling as well. This data further supports the concept that longitudinal function is more sensitive to myocardial damage, while circumferential function, which may remain preserved when the LV begins to deteriorate and functions as short axis restraint to prevent further LV geometric expansion. Another utility of spectral tracking in both MI patients or ischemic patients in general is to assess what we call myocardial ischemic memory. Myocardial ischemic memory imaging denotes the visualization of abnormalities provoked by ischemia and sustained even after restoration of perfusion. So you have a patient with past coronary event and completely reperfused, or even patient who have ischemic symptoms, but you have a normal standard routine echo. And you want to detect subtle ischemia in these patients. We can use what we call post-systolic shortening, which is myocardial contraction that occurs after end-systole, and it is a sensitive marker of myocardial ischemia. In a previous study, the post-systolic shortening persists even after rapid recovery in systolic strain abnormalities, and that assessment of post-systolic shortening is useful for detection of myocardial ischemic memory. This is a post-systolic shortening and refers to the difference between the peak systolic strain and the end systolic strain. This is the shaded space. And in these categories of patients, of course, you can use stress echocardiography, but sometimes stress echocardiography can be difficult to perform for anesthetic patients because, or a patient with severe aortic stenosis or something like that. But because the assessment of post-systolic shortening by spectral tracking echocardiography can be performed in a wider variety of clinical scenarios, we believe that this method would be suitable for ischemic memory imaging. A very important role of spectral tracking echocardiography is patients diagnosed with left ventricular hypertrophy, which may be due to a variety of conditions like hypertensive heart disease, ischemic heart, infiltrative cardiac disorders, diseases, LV outflow obstruction, valvular, valvular, and hypertrophic cardiomyopathy. This patient coming out with advanced cardiac amyloidosis. This is a typical picture of cardiac amyloidosis with left ventricular hypertrophy, concentric in such case, small LV cavity, we have atrial enlargement, the valves are thickened, and even the RV3 wall is thick with some pericardial effusion, and we can hear easily by 2D echocardiography and Doppler measurements tell that there is advanced cardiac amyloidosis. Also, in fourth chamber view, we can appreciate the thickened atrial septum and the biatrial enlargement denoting restricted physiology. And using Doppler measures, you have a restricted pattern of mitral valve inflow. You have pulmonary hypertension, peak rate is more 2.8 meter per second, and all of this denotes significant diastolic dysfunction and restrictive physiology. But the problem is not the patients with advanced cardiac amyloidosis. You have patients coming with some LVH, not full-blown picture of cardiac amyloidosis, and this LVH is for differential diagnosis. So spectral tracking and global impedance strain here can add to the early diagnosis of cardiac amyloidosis. And this paper, a very nice paper about relative apical sparing of longitudinal strain using dimensional spectral tracking echocardiography is post-sensitive and specific for the diagnosis of cardiac amyloidosis. This paper reveals this very nice, a little bit specific and sensitive sign of cardiac amyloidosis even in early stages before full-blown picture of cardiac amyloidosis to be apparent. And they describe this cherry on top sign in longitudinal strain where the apex is relatively spared relative to the basal and segments. And another very nice paper, actually, spectral tracking cardiography cardiac amyloidosis, published in 2019, and derived from a lot of references, like you can see this very nice table and very informative about the brain pattern and what is the typical impairment of spectral tracking cardiography in every LVH patient, like acidic heart, hypertrophic cardiomyopathy, atrial hypertension, arterial hypertension, cardiac amyloidosis, Fabry, aortic stenosis, and so on. And for example, here you can appreciate that patients with hypertrophic cardiomyopathy will have reduced GLS, and the impairment of spectral tracking cardiography GL in global longitudinal function will be more concentrated in the intervention receptor. While in cardiac amyloidosis, we have cherry on top. All are impaired, spared in the apex. While in Fabry disease, we have main impairment at the basal and posterolateral segments. And derived from this very nice paper, we have this diagram about the different spectral tracking morphological patterns in different LVH diseases. In cardiac amyloidosis, in panel A, we have this cherry on top. And in patients with HCM, we have main impairment at the septal segments. But in aortic stenosis, we have a characteristic patchy reduction. It does not follow a specific pattern, actually. Another case of left ventricular hypertrophy, very similar to the previous case, concentric LVH, except that the valves are not that thickened, the intra septum a little bit thickened. And by doing spectral tracking echocardiography, we don't have epital sparing. We have mainly basal segments, posterolateral segments are impaired, and in this case, with genetically proven we have Fabry disease. Rule of spectral tracking cardiography in valvular heart disease, and when reviewing the recent guidelines of 2021 European guidelines of management of valvular heart disease, I can extract from its text every strain worked. And first, they say that indices for left ventricular enlargement and function are strong prognostic factors, but recent studies suggest that global longitudinal strain has greater prognostic value than LV ejection fraction. And another paragraph, they said that new parameters obtained by 3D echocardiography and two-dimensional strain imaging as LV global nuclear strain may be useful, particularly in patients with borderline LV ejection fraction, where they may help in decision for surgery. So if you have valvular lesion with borderline ejection fraction, but you have a reduced strain, this will urge you and push you towards surgery, the usual pathway of follow-up and watchful screening of this patient. Another paragraph about aortic stenosis patient, and they said that assessment of GLS provides additional information concerning the function, and the threshold of 15, and this is the first time to see a threshold, a cutoff, which is 15%, may help to identify patients with severe asymptomatic aortic stenosis. So if you have severe asymptomatic aortic stenosis and you have a cutoff of GLS of less than 15%, so you can go for surgery. Severe mitral regurgitation patients, they can be asymptomatic with supernormal ejection fraction. As you can see here in this example, we have severe mitral regurgitation. Ejection fraction by M1 is 70, supernormal, commonly encountered in severe mitral regurgitation early. And using Samsung, it revealed a 63%. Reserved as well, using 3D echocardiography. The ejection fraction here, ejection fraction here is 68%. All are preserved. While by using spectral tracking echocardiography, we have a GLS of minus 17.8, which is mildly reduced ejection fraction. Sorry, mildly reduced systolic function. So we can go for surgery for such a patient, even if he is asymptomatic. A very important role of spectral tracking echocardiography as well is its role in chemotherapy-induced cardiac toxicity. And the most frequent definition of cardiac toxicity is a 5% decline in symptomatic individuals, ejection fraction from baseline to ejection fraction less than 55, or a 10% reduction in asymptomatic. In the early phases of cardiac toxicity, cardiac imaging has been utilized to detect a reduction in LV function without signs or symptoms of the cardiac toxicity. Strain echocardiography examination using GLS is an excellent predictor of early diagnosis of hereditary early caused by anthracycline treatment because GLS values were significantly reduced. The change of GLS more than 15% from the baseline GLS in all cases before progression to anthracycline-induced cardiac toxicity is an indicator of early cardiac toxicity, and you have to modify or even stop the anthracycline treatment. And this is an example of cardiac toxicity induced by anthracycline chemotherapy. This is baseline, 3 months follow-up, and 12 months follow-up, and you can see how sensitive the spectral tracking echocardiography and GLS changes with the follow-up in motion with and in harmony with the ejection fraction, and even before ejection fraction, baseline is 64 ejection fraction with GLS 19.9, which is good, preserved, and 3 months follow-up, you have 48%, 0.1, while the GLS drop is much greater, 14.9, and at 12 months follow-up, the ejection fraction is corrected, but the GLS is still reduced, so you cannot decide to go back to your regular and routine regimen of chemotherapy. You still have to monitor your patient and change dose or change the regimen of chemotherapy because you still have a GLS reduction. Even during the COVID pandemic, GLS played a very good role. In a recent study shows that left ventricular ejection fraction is preserved in most patients with coronavirus disease. But the LV and the RV spectral echocardiography were abnormal in about 40% of these patients with preserved ejection fraction. And this poorer clinical grade and the clinical deterioration are mostly associated with worsening of RV segmental spectral echocardiography in pattern, suggestive of acute core pulmonary. And the LV and RV spectral tracking echocardiography were strong predictors of mortality, the need for intubation in patients with COVID-19 infection, but ejection fraction is still preserved in all these patients. So now you have to move your leader tool and very good diagnostic modality, spectral tracking echocardiography, from the baby seat to the post seat. And thank you. And I hope next year I will be physically with you. And thank you for your attention.
Thank you, Dr. Mahmoud. And now for the next.
Thank you, Dr. Mahmoud, for this enriching lecture. And it's now time to get a deep dive into an look to a new member in the world of this strain. It's the look to the strain of left atrium, which is usually, I would say, underreported and underlocked. And I guess, probably I'm biased, the best person to speak about this topic is my colleague, Dr. Ala Khalil, who is the director of non-invasive cardiology in Almoosa Specialist Hospital. Please welcome Dr. Ala. And Dr. Ala, please. Go ahead.
15. 15. بسم الله الرحمن الرحيم. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. I will talk about complementary talk in addition to the what already presented by Dr. Ashraf Anwar and Professor Mahmoud Shahata. But I'll talk about left atrial strain. You know that left atrial function, it's the principal rule of the left atrium is to modulate the left ventricular filling and the cardiovascular performance by acting as a reservoir for pulmonary veins, venous return during ventricular systole, conduit function in the pulmonary venous return during early diastole, and booster pump that augment the ventricular filling during the late ventricular systole. Atrial remodeling is caused by collagen deposition in the cell interstitium, followed by fibrous formation. cardiovascular disease causing pressure, volume, overload, and arrhythmic insult. It can result in the adverse atrial myocardial tissue remodeling and increase the interstitial fibrosis. This will lead to the decrease in the atrial elasticity, resulting in the impaired compliance, which is most accurately can be detected now by reservoir LA strain compared to the other echocardiographic parameters. Left atrial strain, it recently published data suggests that prognostic value of the left atrial reservoir function in the heart failure, atrial fibrillation, stroke, and valvular heart disease, it has prognostic value. More recently, speckle tracking echocardiography has been applied to assess left atrial remodeling and fibrosis. Speckle tracking echocardiography method to assess left atrial function, left atrial volumes and functions are assessed by 2D speckle tracking and tissue Doppler imaging. However, 2D speckle tracking is less angle and load dependent compared with the tissue Doppler imaging. Atrial strain is the fractional changes in the length of the entire atrial myocardium contour in the tangential direction, and it is referred as atrial longitudinal strain. When we'll go now to the left atrial longitudinal strain curve, which is the focus of our lecture. Just this curve, it's composed of the three phases. Atrial reservoir, the reservoir phase, which feature left atrial reservoir function during systole, when the pulmonary veins fill the left atrium, leading to the stretch of the atrial wall, and it will correspond to the left ventricular isovolumetric contraction, ejection, and isovolumetric relaxation phase. The left atrial conduit phase, which is characterized the left atrial conduit function during early diastole, when the mitral valve open and left atrial empties its effect to the left ventricle, and it corresponds to the E wave of the transmitral flow, that it is modulated by the atrial compliance, left ventricular relaxation, and the left ventricular compliance. The third phase, which is the left atrial contraction phase, which it represents left atrial pump function, which correspond to the A wave of the transmitral flow, and it depends mainly on the preload in the form of the venous return, and the afterload, which depend on the left ventricular and diastolic pressure. The ICAVI and ASE Industry Task Force consensus, they recommended a standardized LA strain analysis using mainly apical four-chamber view with a frame rate between 50 to 70 frames per minute. Also, they recommended you can utilize both apical four-chamber or apical two-chamber, but they recommend more for the apical four-chamber, as we'll see after that. And also the zero baseline, they both also recommendation for the zero baseline for the LA strain curve is recommended to be at the ventricular and the diastolic by using RR ECG gating. However, you can utilize also the baseline from the onset of the LA contraction, but using in this condition BB gating on the ECG. Moreover, they said also take care about when you are doing a tracking, you have to extrapolate the orifices of the pulmonary veins and, and the left atrial appendage. This is our main scope for the lecture, which is the left atrial strain curve. This is, now we can see this is in our machines, which is the new modalities of the left atrial strain. As we said already from the task force, what they said, you have to utilize apical four-chamber view, which is a preferable, or apical two-chamber view. And it must be non-foreshortened view. Or sometimes you can concentrate on the left atrium with a little bit small for shortening of the left ventricle, which is acceptable. And also, when you are tracing this left atrium, you have to extrapolate the pulmonary venous opening and also the left atrial appendage. Once you started this, the baseline, as he said, they recommended the baseline at the end diastolic phase, which is using that RR gating in the ECG. Starting from the 0, in this condition in end diastolic phase, in this condition it will start with the QRS complex at the end of the QRS complex, and in this condition just to start with the mitral valve closing. During this time it will be felt mitral valve closing, and from this the blood will accumulate until it reaches the peak to the onset of the mitral valve opening, which corresponded in the ECG at the end of the systole here. Okay? And by the transmitral flow, it will be represented here by the starting of the E wave in the transmitral flow. So this will be the LA reservoir phase. The first part, this is the LA reservoir phase. After that, the second phase, which is the LA conduit phase, it starts by the mitral valve opening. It means that from the starting of the end of the from the ECG after the T wave and until the beginning of the atrial contraction till the P wave. And here, transmitral flow is starting from the E wave, which is the transmitral flow during the opening of the mitral valve, up to the A wave, which is the starting of the atrial contraction. So this phase is called as LA conduit phase. And after that, the third phase, which will start here by the atrial contraction from the P wave in the ECG, and from the starting of the wave of transmitral flow, and starting up to the end diastolic pressure here, which is the beginning of the next curve. So this is in the, if you are utilizing the zero, the zero line, which is the end diastolic phase. But if you utilize the pre-atrial contraction or atrial contraction phase, it will be like this curve. In this condition, we'll start from here, which started from the P wave, starting from the E wave of the transmitral flow, and from this condition, it will continue to reach to the end diastolic phase, but this first phase here will be the left atrial contraction phase. No left atrial reservoir as here. It will start by left atrial contraction phase. And after that, once the mitral valve will be closed and start in this condition to the left atrial reservoir phase, which is going up to until to the mitral valve opening, and in this condition with starting of the E wave. And after that, end by the left atrial conduit phase, which starts by the opening of the mitral valve until to the presence of the P wave, which is the beginning of the atrial contraction. So the last part here, it will be the left atrial conduit phase. This is the summary of what we are looking for the left atrial strain phase. Also from here, you can, how can you measure this? For the left atrial reservoir phase, it will be from the peak here till the zero line we are selecting. And for the atrial contraction phase, from the P wave to the end, to the baseline also, and the remaining part here, it will be left atrial conduit phase. And I'll tell you about the normal values of this condition. Also, they say that you have to take care about the tracing. If the patient has interatrial septal aneurysm, you have to include the aneurysm, not to exclude. Because if you utilize like this, there will be, the parameters will be completely different. So they say that you have, if the atrial aneurysm is there, you have to include in your tracing. Also, they talk about the 4-chamber view and 2-chamber view. The 4-chamber view, if you took the left atrial strain, it will have, like this patient, left atrial strain, reservoir strain, it will be 11%. But if in the 2-chamber view, in this patient will be 9%, it will be 7%. So In this condition, if you want to utilize both, you can take the average, which is the 9%. But still, they recommend to utilize only the four-chamber view. Now we'll go to the normal. We are talking about the curves and all these things. What is the normal to assess your patient with left atrial strain? Recently published meta-analysis in about 2,500 healthy individuals showed that the normal values, reservoir strain 39%, and conduit strain is 23%, and contractile strain is 17%. The normal reference range for the echocardiography with the NORI multicentric study found that both left atrial reservoir strain and the conduit strain, it will decrease with the age. And for the healthy individual, we'll find that increase in the left atrial conduction, left atrial contraction phase. Now we'll go for the more practical things about left atrial strain. Left atrial strain and the cardiovascular risk factor. Patient with hypertension, diabetes, obesity, sleep apnea syndrome known to promote the left atrial remodeling. Left atrial dysfunction and the stiffness were more pronounced in the patient with hypertension compared with the healthy individual. And this will cause also affection of the left atrial compliance. That's why it will be affected by the parameters of the left atrial strain. Also, hyperglycemia, it will cause collagen synthesis and interstitial fibrosis, and it can affect left atrial compliance, and it can affect the function. Fibrosis also decrease the elasticity of the left atrium, and this will provoke for development of the atrial fibrillation. Moreover, in the early stage for the chronic renal disease, Cadabo and the co-workers showed that left atrial strain has incremental predictive value over the conventional echocardiographic parameters to detect the myocardial involvement, early involvement in the patient with chronic renal failure. Left atrial strain in heart failure. In addition to Dr. Ashraf Anwar said and Dr. Mahmoud said about the left ventricular strain and the GLS, also left atrial strain has a role in this condition. Santos and co-workers demonstrated that left atrial functional parameters are lower in HFpEF patient. It will be lower in the left HFpEF patient compared with the healthy control regardless of the left atrial size. Don't wait to the size to increase and say that it is already LA dysfunction. Left atrial strain showed gradual progression between the stages of the diastolic dysfunction, which is very important in the diagnosis of the HFpEF patient. And it represents sensitive diagnostic tool to differentiate between the stages of the diastolic dysfunction. Singa and the co-workers found that left atrial strain cutoff of 19% for the LA reservoir strain, it will separate the grade 3 dysfunction from the other grades. LA reservoir strain emerged as significant prognostic value for HFrEF patient also. In this patient, it will be decreased parameters of the left atrial strain. LA reservoir strain increase after CRT and associated with favorable prognosis. There is a study also showing that the importance of the left atrial strain in the different grades of the diastolic dysfunction. They found that already if the left atrial strain between 30% reservoir to 21%, it represents grade 1 diastolic dysfunction. And between 21, can we take 3 minutes only? Sorry. 21%, from 21% to 15%, it represents grade 2 diastolic dysfunction, and if less than 15%, it represents grade 3 diastolic dysfunction. This is very important for diagnosis. How can I go? Okay. Oh, معلش ثواني كده. Just we'll go atrial strain evaluation in the valvular heart disease, just giving examples in the daily practice. In case of the severe aortic stenosis, left atrial volume and left atrial strain are independent predictor of the cardiovascular event. Kamali and the co-workers found that the cutoff value of 16.9% for the LA reservoir strain before the aortic stenosis surgery. They found this patient will be liable to develop atrial fibrillation and left atrial dysfunction after the surgery. Also, they demonstrated that LA reservoir strain inversely related to the degree of the mitral regurg. More severe mitral regurg, you will find more decrease in the left atrial reservoir strain. And also they found that the conduit contraction of the LA function, improvement in the patient after mitral valve clip. And it's very important for the prognosis for this patient. Left atrial strain, which is the most important thing also for the cancer therapy related conduit dysfunction, as Dr. Ashraf Anwar said about it can be utilized because it will show that decrease in the LV strain, global inclusive strain, before development of the overt left ventricular dysfunction in patients with anthracycline and the chemotherapy. The same thing for the left atrial strain also, but now the focus more than for left atrial, more than left ventricular now. Going to the left atrial reservoir strain, it will be decreased more than 10% for the patient with anthracycline therapy. And now the all focus going towards left atrial strain, not the left ventricular strain as before. And the last thing for the effect of the left atrial strain for diagnosis of the patient liable to develop atrial fibrillation, they found that already if there is decrease in the left atrial reservoir strain, it will provoke the patient, mean that future development of the atrial fibrillation, and also for the follow-up of the patient. To conclude my talk, left atrial strain is new and promising method for assessing left atrial function with diagnostic accuracy up to about 95%, more sensitive than conventional parameters of the atrial function, and the changes occur earlier, currently used as a research tool, but shortly it will take over as an important tool for LA function. Thank you, and sorry for...
Thank you very much. I think we'll have a floor for the few questions. Any questions? Go ahead, please, Abdurrahman.
Thank you, Ala. And my question actually to...
Ala, if you come here,
Yes,
and
sir.
Ashraf, yeah, you can come to here. Go ahead, please. لا 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 أنا أوقف هناك. It's okay. Okay. Yes. Go ahead. I'll say so. So what's the question, Abdurrahman? Go ahead, please.
So my question regarding the LA strain. You told us from your slides that the cutoff, the normal values for LA strain, the reservoir is 39, and conduit is 23, I think, and 19 is pump or contraction, yeah. And then you are telling us the to consider it abnormal in the systolic dysfunction, a reservoir should be a 19, something like that. Huh? This is too much reduction from 39 to 19. We know that, in chemotherapy, for example, if the strain reduced from 16, which is normal, or 17, which is normal, to 14, this is already too much reduction. And here, from 39 to 19, I think this is a big jump.
Just to explain this, the normal value for the LA reservoir strain is 39, but they say that it can be up to 26 to be within normal range. Less than 26, it is absolute, there is already a reduction. And for, as you said, asked about that for the chemotherapy and the effect, they said 10% reduction from the baseline. Yeah, suppose the baseline is already 39, so 10% reduction, with the range is less than 32% for the reservoir strain. Okay, but 19, when I spoke about 19, we spoken about the systolic dysfunction, not for the chemotherapy. The systolic dysfunction 19 separate. It was very fast, that's why it's not concentrated. 19% separate grade 3 from the other grades, from grade 2 and the grade 1. And the other study, as I showed you, they said that already from 30% to the 24%, 21%, it will be grade 1 diastolic dysfunction. From 21 to 15%, grade 2 diastolic dysfunction. Less than 15%, it will be grade 3 diastolic dysfunction. Little bit different from the previous study, which said 19 will be grade 3, but close to each other. That's why it is very accurate. Really, it is very accurate. We are now utilizing this in our lab, trying to be that as daily practice, but we are selecting patient with atrial fibrillation, patient with already HFpEF, patient with have hypertension, just to see our, to build our experience about the result, because still it is something new.
Thank you very much.
Dr. Ala, I have one question.
Thank you very much for this excellent review. I have 3 quick questions. Quick, okay. So number 1, always we think of systolic function and we forget the diastolic function. Can we use the same like we use the tissue, the Doppler, to assess the systolic function by using the global longitudinal strain or strain rate to assess diastolic dysfunction, to have a curves for diastolic dysfunctions? This is question number 1. Question number 2, always we have a problem when we have viable segment after myocardial infarction. Is this segment viable or not viable? Will it improve after revascularization? Will not? Is there any rule for the speckle tracking to answer these questions? The third question is this reduction in GLS reversible or sometimes irreversible?
Thank you, Dr. Mustafa, for this, but it's not a fast answer. It's a short question, but it's not short answers. Let's start by viability question. Regarding viability, still till now, it's a secret. Nobody knows by any imaging modality, even MRI, that this tissue is viable or not. Many times that we have judgment by MRI that this area is scarred. And after the viability, so after revascularization by CABG or by BCI, this segment showed improvement. And many times also this segment have 50% reduction of the wall thickness, this mean viable, but even after that it's not recovered. So by any modality we cannot judge 100% that this is viable or not. By strain, we can see the polar maps that this area affected by ischemia. Regardless the number of reduction, it's reduced compared to the healthy segments. But how much percentage of reduction, this is ischemic only, and how much reduction this is scar only, how much this will be recovered or not, we haven't number even with the large studies. This is regarding viability part. Regarding the third question, reversible or irreversible, also depend on the amount of ischemia. This not depend on the number we showed already. For example, the healthy area was more than 17, as we explained before, and this is area affected by reduced strain, but it's 14, it's not 17. It will be recovered after revascularization, we haven't answer. If it's 60%, it will be recovered, we haven't answer. Okay. The first question regarding the diastolic function, as Dr. Ala explained, maybe you are relying on the left atrial volumetric changes or left atrial strain changes during conduit or during reservoir. It will be better than to rely on the curves. There are many studies started now to describe the change of the curves of the diastolic strain, not systolic strain, during the whole cardiac cycle, and they have the parameter, but also it's not standardized by the American Society or European Association of Cardiovascular Imaging. And just a hint or comment, in addition to Dr. Ala mentioned before, why we are targeting strain for the left atrium. It's not like left ventricle. It's they are doing the same we are doing for the LV volume, LA volume. When we are comparing LA volume, either we are talking about the maximum volume, it's just information about maximum volume, will be the reservoir. If we are talking about the active filling, this will be the contractile part, this will be the conduit, This will be the contractile part or pump function. If we are talking about the passive filling, it's passive for left atrium, but it's not passive for the left ventricle. It's relied on the diastolic function. So this is the part we can rely on it for strain or for LA volume, is the conduit part. So the principle have to be in our mind that we are assessing each part of this strain. Patient, for example, AF, and he reverted to sinus rhythm. You need to answer, is this reverted electrically or even contractile mechanically? So now we are not targeting the reservoir, we are not targeting the conduit, we are targeting only the pump part. Thank you.
So can we test? Hello, mic testing.
Hey, sir.
Dr. Osama, right?
Yes, yes. Can close this one.
Yeah, he's an perfect.
No, she's not coming at this year.
Sorry? Yeah, it's working. Yeah, we'll give. Where's Salman? Salman. Mic. Just
خلاص. لا ونتكلم عشان نستفاد بالوقت.
What's the problem now?
I think so.
This is next to this previous, huh?
Yes, sir. Just a minute. Check.
بسم الله الرحمن الرحيم. Dr. Osama now will talk about the topics of easy diagnosis, difficult decision. Interesting case. Dr. Osama is a consultant cardiology, non-invasive in Prince Sultan Cardiac Center. Dr. Osama is pioneer in echo, three-dimensional, and he is our colleague and is also a pioneer in intervention cardiology cases.
Let's start by our first case, and I will pass through because the time. No, we have a first case, 25 years old, Saudi female, no past history of chronic illness, complaint of sudden onset of palpitation. She was referred to National Guard Hospital, and her examination was more or less normal. Her heart rate was little bit tachycardia and irregular. Blood pressure was normal, no fever, normal examination. The only physical finding was that this is obese girl. ECG showing AF with rapid ventricular response. Heart rate at this time about 120, 130. And AF was reverted spontaneously during hospital stay few hours after admission. And chemistry, including thyroid function, were normal. Transthoracic echo was technically difficult because of obesity. Transthoracic echo show mild right atrial dilatation and small pericardial effusion, as you see. And because of difficult transthoracic interpretation and inconclusive study, TE was requested. As you see here, you can see only pericardial effusion, nothing characteristic, but focused here. Can you see anything abnormal? Just if this is tricuspid valve, what this? If I hide this part, this is metaesophageal for chamber view, and there is something. Okay. Again, it's more clear. This is tricuspid valve, and this is something behind the tricuspid valve. And this is in the bicaval view. You can see large sac behind the tricuspid valve. Again, this is explained view. What about this? What's this? Which was not clear by transthoracic echo. Look at this one. This is the very important sign. When I inject contrast material, it's very vena cava. What could this be? What will be your impression? Diverticulum. Okay. Maybe. Yes. So, what will be your next investigation? CT or MRI. Okay, agree. So, we forget about something very simple, very important, which is the chest X-ray. And as you see here, the right side of the heart is markedly enlarged. Okay? CT or MRI. What can you see here? You see this, what we saw in the transesophageal echo. A large communication between the right atrium and this diverticulum or this pouch behind the right atrium. Another important finding, how much this mass is so close to the sternum. And this is very important when you will inform the surgeon about this. So, the question now is 25 healthy person came with paroxysmal AF, accidentally find this mass. What will be your decision? Operate or not to operate? Who agree for operation? Okay. Who will disagree with operation? So the majority disagree with operation.
I wouldn't consider you asymptomatic. You have AF.
Okay.
ده اللي تيجي سايق دبابة عندك سلاح لا مط.
يعني you will send the air for doctor. You will send the air for operation because of AF.
AF is a very common symptom.
Okay. Okay. طيب, we will continue.
And we don't have other reason يعني.
So now we have a conflict. We have a large pouch which may rupture anytime and it will be lethal. And we have completely asymptomatic patient. Anyhow, after discussion and after controversy and after fighting with each other, we decide the safe for her is to send her for the operation. Okay, and this is the 3D, and as you see, this is the large pouch or large diverticulum. Even when I started to write the report, I was confused. What is the exact term? Is it diverticulum? Is it pouch? It is abnormal extension? Anyhow, and this is at the time of operation. The surgeon was cutting the sternum very carefully because it is very close to the chest wall. And this is not the heart. This is only the sac you see, or the diverticulum you see. And when we open, as it was shown by the transesophageal echo, it was full of fibrous tissue. Yes. So at operation, a huge pouch communicating with the right atrium was there. The pouch filled with a multiple septal fibrous band, and the pouches was very thin wall and very liable to rupture. That's why when we had the operation, we feel that we choose the right thing for our patient. Our diagnosis was huge right atrial appendage. Huge right atrial appendage. Up to our knowledge, the only few cases all over the world was diagnosed with this huge right atrial appendage aneurysm. And this was on the largest right atrial aneurysm recorded. The operation and post-operative period was uneventful, and the patient was discharged in a good general condition. And the lesson learned from this study: never underestimate the importance of simple investigation like chest X-ray. And number two, TEE is very valuable when the diagnosis, when the 2D is not helpful.
We can discuss later. We can discuss later on after just to flow to keep the flow.
Okay, عشان الوقت يا دكتور هنرجع. Second case, 74 years old Saudi male patient, hypertensive on regular medication. His main complaint was light dizziness. He was generally stable. He was referred to our center with strange diagnosis, subaortic membrane, okay, for evaluation. On examination, nearly normal cardiac examination, normal lab, ECG, sinus risk, non-specific T-wave exchange. This is his echo. What you see here, there is something attached to the interatrial septum. Okay, and this mass is mobile. This mass about 1.5 centimeter below the aortic valve.
Doesn't look like subaortic.
Okay, yes, yes.
Fibroelastoma.
Yeah. Okay, and this mass does not affect the valve function, and there is only trace of aortic regurg not related to the mass. This is the zoom view of the mass, and this is the 3D zoom, and this is the 3D view of the mass, and this is the mass behind the aortic valve. So, what is your initial diagnosis? Fibroelastoma. So I think most of us agree on the diagnosis. But the most accurate term is atypical fibroelastoma. Anyhow, this is not the question. The question now, what we will do? Leave the patient?
No.
He is totally asymptomatic. The complaint is not related to his. We cannot judge that this mild dizziness is related to the fibroelastoma. It is, I will tell you the two opinions. It is firmly attached to the septum. It does not affect the valve function. This is who vote for leave the patient alone, don't touch. The other, for fear of embolization, we should operate. Okay? And the final decision was to send the patient for operation. Okay, so we have risk of surgery versus risk of embolization. He's elderly patient. Okay, and this is not a gift for the surgeon, and this is the mass was removed, and this is, because I love 3D, this is the comparison between what I found in the echo before the operation and what we get at the operation. Decision making is not easy. Wise decision make a big difference. Thank you very much.
ايش؟ الانيوريزم الباثولوجي رايت اتريال انيوريزم طلع باثولوجي انيوريزم تيشو. اوكي.
We can leave the question after I think the set description. لا نحن لسه عندنا question.
السلام عليكم ورحمة الله. I'm Dr. Haytham Osman Hamdallah, consultant cardiologist from Almaya General Hospital, Hufuf. First of all, I would like to thank Dr. Ala and the organizing committee for inviting me to this conference. Our second speaker will be from Egypt, Dr. Muhammad Ayman. He is a consultant cardiologist and an emeritus professor at Faculty of Medicine, Alexandria Hospital. He has huge experience in echocardiography, transesophageal echo, interventional echo, and he had presented a case yesterday I think most of us have never seen before. Welcome again, Dr. Muhammad Ayman.
So this topic will cover the following items: the context and definition of focus, energy composition, pathology, real-life physical demonstration, and conclusion. So what start with? What is focus? Focus is an ultrasound performed by a clinical physician himself. So the patient is going to have the ultrasound by the patient at the point of care. So there is no referral and it is not a consultative ultrasound. Who's going to do a focus? Is it the cardiologist and all the resources as we used to see? No. Focus is not limited to a specific specialty. The physician, whatever the specialty, specialty is the one who is going to do the ultrasound. And it can be applied to any body organ. Regarding the place, this ultrasound examination will be done and interpreted at the point of care. I mean, there is no patient transfer. So it's an ultrasound which is done by the attending physician to any body organs at the point of care, wherever it is, in the ICU, in the CCU, in the cath lab, in the trauma, in the ambulance, or even at home. If the patient had collapsed at home, they should go with a portable ultrasound and do this quick examination at home. So basically, cardiac focus is a quick qualitative echo. We are not going to do a detailed consultative echo with different kinds of measurements and calculations. It's just a quick qualitative echo to understand the pathology and the problem with our patients. So what we are looking for. Very quickly from outside here, that there is the status of the size of the floor chambers here. Is the left ventricle big or not? The RV, right atrium, left atrium, side. I'm going to look to the wall thickness, and I will look to the contractility and the wall motion of the left ventricle and the right ventricle. Any problem with the valves? So, any effusions, size, wall motions, any problem with the valves? About the volume status by checking the IV size and the collapsibility of the inferior ventricle. So what are the indications of cardiac focus? Focus is important during resuscitation from cardiac arrest, evaluation patients presenting with chest pain, dyspnea, or syncope, hemodynamic instability patients presenting with hypotension or shock. You can get an idea about the CVP of the patient non-invasively, and this focus helps in guiding vascular access if I want to insert, for example, during insertion of central lines. This could be helpful during the insertion of the catheter. How to do it? How to do this quick look? Basically, we have 3 windows and 5 views. So I'm going to start from the parasternal long axis view, moving clockwise to the apical window, then to the subcostal. Quick look. So from these 3 positions, we are going to take a quick look about the heart from, by getting these 5 views. Parasternal window here, I'm going to check for the parasternal long axis, compare the size of the RV to the left ventricle, the wall motions of the septum and the intralateral wall, any problems with the aortic or the mitral valve. Then taking the probe to the short axis view, looking to the RV size compared to the LV size, is it okay, or the RV is dilated, looking to the wall thickness. Looking about the same things as in the apical floor chamber, but here you can see effusions, tips to guide you for pericardiocentesis, and you can check for the RV3 wall thickness, because we usually measure the thickness of the RV3 wall from the subcostal window. On the same window, just by rotating the probe to make the ridge at 12 o'clock, you can see the entrance of the IBC and have an idea about the volume status, and you can estimate even the central venous pressure by checking the size and the collapsibility of the IBC. So whenever you're going to check for the IBC, we have 2 important pitfalls. Number 1, don't miss the IBC for the aorta. I mean, this is not the IBC, this is the aorta, it's a pulsatile vessel here, and don't confuse with the IBC. This is because the 2 vascular structures are very close to each other. So if I'm going to put the probe here, you are going to see the aorta. You have to go to the right loop a bit and check for the IBC, and also the aorta. You can put the sample volume here, and I'm going to have this pulsatile aortic Doppler loop. Another clue to differentiate the IBC from the aorta is that the IBC ends into the right atrium here. So whenever we are going to check for the IBC, we are going to see this termination of the IBC into the right atrium, and this is the hepatic vein. The second pitfall is the assessment of the size of the IBC. Okay, so in this subcostal window, this image, as you can see here, that looks small and it collapses. This could be simply hypovolemia, but It could be also that you are putting your probe and cutting the ultrasound beam is cutting the IBC at the edge. So this will give you a smaller dimension for the IBC. Manipulate the probe and make sure that your ultrasound beam is cutting the IBC in the middle to get the proper size of the inferior vena cava. So this is the same IBC for the same patient. Now here I am off axis. Now I adjusted my hand to catch the IBC in the middle of the IBC, and this represents actually the true size of the inferior vena cava. Besides the volume status, by checking the IBC, we can estimate the mean right atrial pressure or the central venous pressures by just looking about the diameter of the IBC and the degree of its collapsibility, and from this table we can estimate the range of the mean right atrial pressure. What about the different pathologies? Whenever I want to look a quick look with a focus about the heart and cardiovascular system, as I told you before, we are going to look for these simple things. Look for effusion, pericardial, pleural effusion. Then the two main vessels, the aorta for dissection or aneurysm, and the IBC for the volume status and to estimate the central venous pressure. So start with the effusions, heart, lung, IBC status, the proximal portions of the aorta. Take a quick look about this before. Then, going to the other views, you can go to take an idea about the LV global function, any regional wall motions abnormalities, the valves, the RV size, the RA size, any other manifestations. So whenever you are going to put this in your mind, I'm going to look at pericardial pleural effusions, IVC, the proximal portion of the aorta, any pathology in any of them, go deep to the ventricles, to the valves, and to the aorta. This is an example for a normal LV size, capital dimension, a normal RV size, very proper and very good contractility. Valves looks nice, some hypertrophy here in the septum, no effusions. So this is a quick look about this. This is the normal, and this one is having an apical dyskinesis here. Probably he had an anterior walrum eye, and if you are going to calculate the ejection fraction, it's going to be low, less than low. So applying the cardiac focus in different clinical presentations, sometimes we are frequently, and we are confronted with patients presenting with dyspnea. So what is the cause of the dyspnea? By just putting the probe, you can catch the actual cause for the dyspnea. So the dyspnea could be due to bad problems like patient with aortic stenosis, mitral stenosis, or a severe mitral valve irritation. Or the dyspnea could be due secondary to a problem in the pump function of the heart, and like in this patient's was echo show lower hypokinesis either in the long or the short axis view. Or sometimes the dyspnea might be associated with signs of the right-sided failure in this problem. This patient is a non-compaction. You can see that the LV function test and the RV free wall motion is seems to not be contracting well, and we have dilated both ventricles with dilated both atria. So you can catch up why the patient is suffering from such symptoms. Sometimes the dyspnea might be present in patients with a preserved systolic function, and the problem here is secondary to LVH, but LVH could be secondary to amyloidosis, like in this patient, and I diagnosed amyloidosis by this abnormal sparkling appearance and the velicity of the interventricular septum and the free wall, and the thickening of the mitral and the tricuspid valve. Here, another pattern of hypertrophy in this patient with apical hypertrophic cardiomyopathy, what we call it the Japanese type of hypertrophic cardiomyopathy. Here, the dyspnea is secondary to LV diastolic dysfunction rather than LV systolic dysfunction. Or the dyspnea could be secondary to pulmonary hypertension. As you can see here, we have a gross dilatation of the RV, hypertrophy of the RV wall, D-shaped sign denoting D-shaped sign of the left ventricle and the interventricular septum. This denotes a chronic systolic overload and a dilated pulmonary artery. So you can catch up why your patient is dyspneic. Another cause of dyspnea is this effusion, circumferential effusion, as you can see here, pericardial effusion, I mean. Or if the patient is having severe hemodynamic instability and even potential shock, this would be secondary to tamponade, and this is an example of a swinging heart. Or the dyspnea is not related to the heart at all, and this is secondary pleural effusion. With your probe, you can pick up that there is pleural effusion in the patient. Sometimes the patient is having both pericardia and pleural effusion. How to differentiate between pericardial and pleural effusion? You can see some fluid here. Is this an extension of the pericardial effusion? As we know from the anatomy here, we should look at the descending thoracic aorta. So the descending thoracic aorta is posterior to the heart and the aorta is anterior to the lung. So in the ultrasound, whenever you see this descending thoracic aorta, if you have a fluid collection posterior to the aorta, this is pleural. And if it is anterior to it, this is a pericardial effusion. So this patient is having both pericardial and pleural effusion. Evaluating chest pain. Sometimes we are seeing patient presenting with chest pain like this. Just by putting the probe, you can see this pericardial effusion. But in addition to the pericardial effusion, you can see this multiple fibrous strands. This means that there is an active inflammation inside this pericardium. And this patient is suffering from acute pericarditis, which could simply explain his chest pain. Another patient with pericardial effusion, and we have here resting regional motions abnormalities, so probably this chest pain and the patient is suffering, still suffering from it, is probably secondary to myocardial ischemia. Another example for a chest pain is aortic dissection. You can see here the moving intimate flap